And now, Alice Yu, assistant member in the Department of GU Oncology at Moffitt Cancer Center in Tampa, Florida, is going to speak about the role of biomarkers in patient selection for focal therapy.
Thank you for that introduction, and I have no relevant disclosures for this talk. The role of biomarkers for patient selection for focal therapy, I think this is really a space where there are probably more questions than answers. Let's start with the case. So a 67-year-old male who's otherwise healthy with a PSA of 4 has an MRI showing a very small 5 millimeter PIRADS 4 lesion at the left peripheral zone mid-gland, no extraprostatic extension, no seminal vesicle invasion. On biopsy, you find grade group 2 prostate cancer only in the ROI with very low percentage pattern 4, and all of your systematic cores are negative. So the next steps, things that are going through your mind are, is this a patient who's suited for active surveillance, focal therapy, or whole gland treatment? Is there a role for biomarkers in this space? Answer, sort of. So we know that there are gene expression assays commercially available that can help with risk stratification, particularly in the low to intermediate risk group. This is a publication looking at Decipher, and it showed that it significantly improved the prediction of the risk of metastasis and death in this population, and it significantly outperformed traditional risk classifications such as NCCN or the Capra score. There are some who have suggested that we should combine genomic classifier assays with clinical pathologic variables to create a novel clinical genomic risk classification system. And these type of systems have been shown to outperform traditional clinical classification systems as well. Particularly when it comes to active surveillance using real-world data from the MUSIC Consortium, we see that those with a higher Decipher score were more likely to undergo disease reclassification and treatment. Though how does this translate to survival is unclear. So going back to our case, what is the role of these gene expression assays? Well, it can give us some guidance as to treat or not to treat. However, it doesn't give us any information in terms of treatment escalation, whether this patient should undergo focal therapy, whole gland, or if they undergo focal, how will they do? When it comes to treatment escalation, there is some data in the radiation space, but we really can't extrapolate this and apply it to focal therapy. We know that with intermediate risk patients, those who had a higher risk genomic score it was prognostic for biochemical failure, necessity for secondary therapy, distant metastasis, prostate cancer specific survival, and overall survival, specifically in an intermediate risk category cohort. And that the rates of distant metastasis at 10 years was significantly different at 4% versus 16% depending on your genomic classifier. And based on this, our radiation colleagues sometimes use these genomic classifiers to determine whether or not to escalate to the addition of ADT in this population. However, again, what about focal therapy? Really, we cannot extrapolate from these type of data, and it's largely unknown how these assays impact our treatment. The other big issue with focal therapy is the heterogeneity of prostate cancer between multifocal, different lesions in a multifocal case, but sometimes even within one area of disease. And your assay is only as good as what you sample. Most commercial assays only sample the area of highest grade disease, so you really don't know what's going on in every little piece of the prostate, which when it comes to focal therapy is extremely important. Therefore, again, the problem is sampling, and your assay is only as good as what you can send to the lab. Artificial intelligence, so there's been a lot of talk about this. We know that there's been some groundbreaking work in the radiation oncology space. In intermediate risk patients, MMAI is now predictive of clinical outcomes and has really helped guide radiation oncologists when it comes to utilization of ADT and escalation of treatment. But again, we cannot extrapolate and use this type of information for focal therapy. So the role of biomarkers, in what we know is that in patients with favorable intermediate risk cancer, biomarkers such as a genomic assay may influence your decision when it comes to treatment versus surveillance. However, really has no role, in my opinion, when it comes to patient selection for focal therapy or predicting treatment success. And this really highlights the lack of data on the role of biomarkers when it comes to focal therapy. Now, moving on, a couple years ago, this society published a Delphi consensus on the role of molecular biomarkers when it comes to focal therapy, and there was no consensus on the utilization of biomarkers. However, I do think moving forward, when it comes to research in this space, the authors of this panel described very eloquently what are the ideal features and endpoints for molecular biomarkers that we need to look at. So an ideal biomarker should be able to improve the accuracy of ruling out high-risk disease. It needs to rule in the presence of intermediate risk disease. It needs to rule out clinically significant disease outside of the targeted area. And it should have the ability to predict those at high risk of recurrence after focal therapy. And more importantly, when it comes to recurrence, it should have the ability to predict those who will need radical treatment after focal therapy. And finally, when it's incorporated in clinical decision-making, the biomarker should overall decrease the recurrence rate after focal therapy or help us decrease the likelihood of recurrence. Now, where is the answer when it comes to biomarkers? We know that when it comes to the tumor microenvironment after focal therapy treatment, there is a whole cascade of events that happen. And understanding the tumor microenvironment response to various technologies can be the key in discovering novel biomarkers that have clinical utility. And it's really interesting how different technologies can lead to different tumor microenvironment changes, and this is something that we need to keep in mind. Perhaps the answer is in the interface between the gene and imaging. We heard a fantastic talk from Dr. Klotz earlier talking about this really exciting space that deserves more research. And lastly, maybe the answer isn't a biomarker at all. It's just about refining our imaging techniques. Focal therapy is very highly reliant on imaging, and there's certainly a lot more work that can be done in this space as well. So to conclude, there is no role for the routine of biomarkers when it comes to patient selection for focal therapy as of yet. Thank you.